I come right here, Dr. Servin. So Dr. Servin is a professor of neurology in our departments with a joint appointment. He was the chair of neurology in Arizona, just came here not long ago to join us and our beautiful campus. And we're so excited to have you, of course, Dr. Servin. You know, Georgetown University, Louisiana State University for medical school, and then went on to become a resident at the University of Minnesota, and then UPenn time, and then Temple, Thomas Jefferson, and then eventually making his way in 1999 in neurology at Mayo, Phoenix, Arizona, where he rises to the ranks to become a professor and chair of the department, multiple honors and awards, a tremendous influence on the literature, a tremendous partner, a great friend, an amazing colleague. Anytime we call upon him to see our patients, he's 24/7 available to them. He's got a tremendous relationship with our patients, a high impact, and the literature, you can actually see his H-index through Scopus as well as Google. So we are very, very excited, obviously, to have you at a personal level. Like I said, it's just quite an honor to have Joe right here with us, enjoying our time. You know, is extraordinarily benefited from having someone of his caliber helping us take care of our patients. So Dr. Servin, without any further ado, thank you very much for being here with us this morning and for giving us your talk. And I pivot to you so that way you can share your screen.
I appreciate it. Let me get to that screen right now. There we go. And let me get to the right manner. There we go. Q, thank you so very much for this opportunity. I'm going to probably talk on something that maybe perhaps some of you know something about, but my guess is a lot of people probably have not had an opportunity to kind of dive deep into this issue of aviation neurology. As you saw, my area of expertise has always been in the area of seizures, but this is one of those areas that has arisen simply from actually a seizure patient who had the misfortune of having a seizure while on a flight, and that led to an odyssey and to a paper. And next thing you know, I am working with the FAA and now a certified aviation medical examiner for them. So I'm excited to kind of bring this because I think what you'll learn from this, and this is me coming from it from an epilepsy neurology standpoint, is that clinical outcomes are extremely important in terms of how they're framed and how we look at risk. And when you look at pilots, this is an interesting example where it's high stakes in every direction. It's high stakes for the pilot because their career could be over if things don't go in their direction. It's high stakes for the public if this doesn't get it right in terms of something happening. So I'm going to try to get to the high points and walk you through just what does aviation neurology look like at this point. Here are my objectives: to recognize neuro issues common in pilots or airmen, recognize those aeromedical significance of certain neuro conditions, I can't do them all, and then recognize the conditions that have to be deferred to the FAA system, which is an entire medical approach in terms of evaluating risk. This is very pertinent to the neurosurgeon because as I go through records, a lot of the conditions that you all have operated people on often show up for review at these FAA panels. Let me bring this to you in a way, and you don't need sound for this, but here I'm going to take you to a Saturday morning. There's a lot of aviation geeks. They love to film planes taking off and landing, and they happen to be right near the runway 27 in Chicago O'Hare on a Saturday morning, and they filmed this. And I'll ask you to kind of decide what is it that you're seeing, and I'll show you how it's pertinent. FedEx DC-10. And I don't know if you caught it already, but remember, this is being filmed right at the edge of the runway where the public can see it. And then it'll go nice and quiet. And it goes pretty well. What you saw there, and this is how life is in this day and age of social media. I don't know if you caught it, but what was happening is that those landing gear was coming down very, very, very late. If you saw it, those landing gears should have been down the moment you kind of had the camera veered on the plane. It wasn't until at the end you saw that that landing gear is there. Well, one of these aviation folks filmed that literally, that DC-10, that very innocuous, safe landing at the end. And they put it up on YouTube under, dude, where's your landing gear, was the element. Well, the FAA got to their attention, and they, at the end of the day, ended up investigating it. What you weren't, and here's the backstory, what you were watching there, and this is where I kind of get involved in my area of expertise, is what they found is that that airman, the captain of that particular flight that you were just seeing on that, was found to have an oligo, and that was actually, he was having a little focal seizure up in the literally while piloting that, and it only came about when someone kind of did this. My point is, this shows up right in front of us, and those are the high stake elements. Now, I'll walk you through, well, what happens to this person, and we'll kind of go from there. But this is the type of thing where it just shows the high stakes for that person. They were not flying, I can assure you, very quickly after all of that came to light. But this is the type of thing that emerges, and why this is so huge. Now, the question that comes in is like, well, who would get to know this if they didn't have a tape? Well, here I wanted to kind of just walk you through just the system of how pilots are looked at, and then we'll walk into the neurology part of it. First of all, there are different classes of licenses, but with each class of pilot's licenses, there is a different medical certificate and length of time that medical certificate is gone. So pilots are some of the most watched people for obvious public health issues, but from a medical standpoint. So a first class pilot who flies for an airline, they're gonna get an exam every 6 months if you're 40 years or over, or every year if you're under the age of 40. If you're a charter pilot, you get a second class, which is about good for a year. And if you don't have this, you can't fly. This is an addition to your pilot's license. And then third class are more for recreational, private pilot. And this can go anywhere from 60 to 24 months. There is even now a fourth one, which we do not involve ourselves with. This something called basic med. I'm not going to get into it, but that also has a more of a longer recreational direction. My point is that you're being monitored, if you will, constantly for all of these issues from a health standpoint, and neurologic issues pop up. So our role, a physician role or an aviation medical examiner role in certifying a pilot, first of all, you have to have a designation as an aviation medical examiner, which is done by the FAA, a test, an exam, classes, things of that sort. But then once you're doing that, you have to make sure, and here's just going to be some obvious points. You have to make sure you got the right diagnosis, a prognosis, if there's an event of some sort for future recurrence, what could the health issue impact aviation safety, and then provide adequate information for determination certification. In other words, there's an entire world of physicians, including neurosurgeons, neurologists, I might add, that within FAA that look at this stuff to see if someone can fly. Now, you may say, well, what are those things that, like, what takes you off the table? These are the disqualifying medical conditions as listed by the FAA and always growing to some direction as we understand different conditions. I placed in yellow those that are neuro-based that will not allow you to fly, or at least will get additional look-see. But if you'll see, things such as a disturbance of consciousness without satisfactory explanation of cause, if you have it recurrently, will get you out. Look, epilepsy has been called out right out by name. No, you can't fly. And there are rules, there are caveats to all of these, but this is what's out there. A lot of cardiac, curiously and very good, psychiatric ones such as personality disorders that manifest as overacts or psychosis. Notice that substance abuse and substance dependence is in there, so another psychiatry indication. And then loss of nervous system function without a satisfactory explanation of the cause. So neuro is well represented in these disqualifying medical conditions, but there are caveats. And believe me, people will search out the caveats. So here's the obvious points. Details matter. The history, the what happened, what went on with the pilot or something like that is huge. So what the reports state, what people know is the most important thing that we have, because by the time that one sees them, these are also relatively healthy people outside of these things. These details are going to matter in terms of evaluating risk. And this is what becomes really important in this situation. When a neuro eval is done on a pilot for any purpose, whether it's a neurosurgeon, a neurologist, or anyone involved in the neuro world, these are the things that they are looking for. And I'm going to go specifically into some of them in a moment, which are germane to the ability to fly. So on the medical history side, they'll look for headaches because migraines, as I'll show you in a moment, is one that they do flag, particularly if there are visual auras, as I'll show you in a moment. Dizziness or fainting spell, that speaks for itself because you just can't do that. You cannot be incapacitated suddenly. Unconsciousness for any reason, that has to be asked. Neurological disorders, the obvious ones, seizure, stroke, paralysis, history of traumatic brain injury, movement disorders, being admitted to the hospital. On the exam side, you're looking for neuropathies and neuralgias. On the spine and musculoskeletal, you're looking for things that could be incapacitating, like myasthenia gravis or other neurologic disorders. And then on the neurology part, there's everything, the tremor, the cranial nerve, sensory motor. And then in this day and age, which I should mention, any form of mild cognitive impairment is a disqualifying feature, as should be fairly evident. But there are challenges to this, because by the time that they arrive to see someone like myself or any of these individuals, there's a lot of distance between the evaluator and the aviator. There's unintentional or incomplete information that can show up. And what I mean by that is that people know that these are high stakes, that you could lose your career. So they don't want to necessarily disclose everything. Everything always looks rosy and lovely every time I see them. And then you get into the details and like, well, this doesn't look so pretty. But that's the bottom line. This stuff gets looked up very closely. And then there's a lot of reliance upon the evaluation, everything from the emergency room notes, the ambulance notes, because this is gonna, as you're gonna see, there are huge differences between how different neuro conditions are treated for a pilot. And so the diagnosis becomes everything, and outcome becomes everything. Right now, while there's a huge surge for people are flying again, despite our COVID surge right now, but the airlines are incredibly busy if anyone has flown in the past few days or weeks. And so there is a huge pressure to return everyone to fly. I've seen that the number of consultations to me for pilots wanting to get back to the air have almost doubled to tripled in the past couple of months as airlines go to rehire. And the bottom line is those pressures, they just don't matter. What matters is the safety issues. You can't speed up healing and you can't speed up observation time. But I do want to give you a glimpse as to how they've come up with different approaches to evaluating risk for something like flying. So let me kind of go take you back, and I promise keep this part super brief, but I'll 2 slides on this. There is a very explicit approach to risk that the FAA uses, which they've come out with. This risk approach was started in the late 70s and in the early 80s when there were more passenger-based airline crashes than there had been any time in the recent future. And at that time, they were stating that they found that there was about 0.2% of fatal accidents per million flying passenger hours per year. They wanted to have that so that anything they can control, that is anything that whether it's the plane itself or the pilot crew, they can have that. And so they came out to an area where, and this was a series of risks, and they started in the world of cardiac, and then it went into the world of neuro, where they said, this is what they can accept. 1 per 100 cases of sudden incapacitation risk during a critical period. Critical periods considered takeoff and landing for the 6 minutes each of those relatively takes, so about 15 minutes. How often it can occur on a yearly basis and how often it occur on that yearly basis. When they did the multiplications, so this is what they did, is they came out with a risk threshold for a crew member, a pilot, and they assume that there is no secondary pilot, even though all airlines have 2 pilots in there. They assume only 1 pilot in that area, that they came out with what came to be known as the 1% rule, or 1 per, as you see the number of zeros there, in terms of what they'll accept for sudden incapacitation or a disqualifying figure. So this 1% rule, and this is where we have to apply this to neurological issues, is the risk threshold applied to a medical fitness of the pilot. That means that any condition, whether it's a heart attack, strokes, or fainting or syncope, if you have a greater than 1% risk every year, that is not going to, you have to go below it. That is the threshold. So if there's a 2% risk that they're going to have a seizure in the coming year based on how they look, or a 2% risk of a stroke or an aneurysm being burst, then you're out. You are going to be held back. And that's a pretty stringent element. But this is an interesting way of how clinical outcomes gets translated into policy, whether you like it or not. That means some people unfortunately do not get the benefit of the doubt, and some people can skirt it through. And as we start to learn more about genetics, risk, and radiology, particularly imaging such as MRI, gets like the 7T here at Mayo and other things like that, start showing more pathology, the more studies that have to be done to understand risk in order for people to want to know what is the right risk threshold. So what are the neurologic concerns in aviators? There's really just 2 things. It's the risk of sudden incapacitation, that's for seizures, syncope, or a migraine aura. Or if you know you have a functional impairment, they've had the stroke, they have some type of traumatic brain injury, does the functional impairment impact them? Now, functional impairment, you can study that now because they have beautiful, gorgeous air simulators that they spend millions of dollars on figuring out whether you are safe to fly. And they can also bring people to you to watch you fly. So you can figure out the functional impairment to some degree. What is harder is incapacitation risk, because that's the seizures, the auras, the stroke, the aneurysm burst that you're trying to figure out. The other thing that's very common and difficult on functional impairment, which is now a bigger issue, is cognitive impairment. And that is one that they struggle with to figure out where does that play out and how to predict this in the best of scenarios. I will say, as recent as 2017, neuro conditions are the primary reason why even in Norway, to give you one country, they lose your license. In America, it's actually cardiac. But here, the numbers seem to always be increasing up as we see the number of cases arise. So what are the common conditions we see in pilots? It's the same thing we see in the general public. There are 665,000 certified pilots in the US, at least for 2019. These are the things that we kind of see most frequently: migraine, syncope, loss of consciousness, traumatic brain injury, seizure, neurodegenerative, strokes, transient global amnesia, believe it or not, and then tumors. And those are the ones we kind of always struggle with. So I'm going to quickly get you through a couple of approaches, a couple of conditions very quickly through cases. If it's syncope, it depends on whether it's heart or brain as the issue, and whether it occurred in flight or whether it could be recurrent. I want you to kind of note, these are how we apply the rules. If there is a vasovagal syncope, they passed out from a blood draw, marked sleep deprivation, you are going to be able to, and oftentimes, certify these individuals, and they will be able to fly, assuming that there is a good reason, good explanation, and there's almost not going to be any time that they're going to have to wait out. It's just that this has to make sense, that it actually fits. But if there's more than one event, you can't explain that there's a cardiac issue, you're stopped, and you're going to have to get evaluated by the FAA people in order to kind of understand whether they can fly again. So there's a difference, and that's where the details matter. When you come to seizure, a single unprovoked seizure in adulthood with no risk factors, there's about a 32% recurrence risk at 1 year and up to 46% at 5 years. This is if you have a normal MRI, normal EEG. So what's going to happen with a pilot who presents with a seizure? It's going to vary rather dramatically. If it's a single seizure, there's no risk factor, normal studies. The current policy says that you have to be 4 years seizure-free. And here's the important part, 2 of those, you have to be medication-free. All seizure drugs are banned by the FAA for any pilot, regardless of whether you're using it for seizure, headache, or any other purpose. So things like gabapentin, it's gone. Things like Topamax, which is used in migraine, you can't use that. So seizure, a single seizure, so if they had an alcoholic bender on a layover, you're out. You're going to be out for 4 years almost. Now, if you have more than one seizure, that's over. You're considered epilepsy, and in order to be able to fly, even though I said that's a disqualifying feature, you have to go in remission. Remission is 10 years seizure-free, 3 of which were medication-free. That's a big deal in an epilepsy surgery deal, because we have to make sure that if there's a pilot, and there are a few, I might add, that if you're seizure-free for 10 years, then you're going to be able to make it, assuming that the EEG is completely clean and there's been no evidence of it. So again, here's where we get into how modern neurosurgery, where we can do things for conditions, play into the risk equation. Let me kind of play one quick video of a pilot that I had ages ago that basically was having events. And it's very quick. Just take a look over her arm real quick over here. Here it is. That was it. That little event ended up being, she was LG1 autoimmune encephalitis positive. She had focal aware seizures. She never lost consciousness, but she was doing that during a flight. And her co-pilot said, what was that? And at the end of the day, even though she never lost consciousness, this was reported, it was kind of attributed to the temporal lobe. Fortunately, she had something that could be treated easily, was very responsive to immune therapy. But just like many of you in neurosurgery, where I know surgery is breathing, as one neurosurgical colleague told me, flying is life for a pilot. She waited out her decade, came off all her meds before, and she got back to flying before, so that she could return. That is how committed these folks are. But that's the type of stuff that you have to do. Here's an EEG from a pilot from a major airline that I saw, I'll just say recently. And I will tell you that this person simply got an EEG because he had a headache. And by accident, this popped up and this person had been flying. My question to you is, would you allow that person to fly? There's no clinical events. There's nothing there, but I'm seeing this, and that is a generalized spike wave genetic abnormality. Sadly, or not sadly, or thankfully, he's no longer flying. But this is the type of thing, because I can't say that there's a less than 1% risk per year that he's not going to have a seizure. But I don't know what happens over years, because this person may never be able to fly, and sadly the EEG kind of nailed it. On the migraine side, you think, well, a lot of people have migraines. Well, the one that we worry about here are the visual ones, or the ones that progress further into the arm. So here are examples of what a visual migraine can do. The little kind of little sparkly lights, or the fortification spectra, or any of this type of picture. The problem is that when they report this in the middle of final approach or a flight, and many of which I've seen have, that's a problem. And therefore you have to find ways to mitigate visual migraines, because those are called out for not being able to fly and have to be managed. So we have issues such as distracting, these are important because a pain may occur, the symptoms that occur. Let me point out, here's where migraines, a common condition, are huge about medication. Beta blockers and a calcium channel blocker, so propranolol and verapamil, you can fly with that. ACE inhibitor, you can fly with that. A triptan, you can't fly for 24 hours on the triptan. A non-steroidals, okay. Non-sedating over-the-counter, okay. Opioids, anticonvulsants, and antidepressants, you can't. Botox, they have to be looked at. The new CGRP agents, they have to be looked at. So and then dietans are not allowed. Those are the new groups, and stimulators. Give you a picture that the medication profile has to be perfect in order for these people to fly. There's even recommendations for this. The last thing I will say is on traumatic brain injury, is that here's a case of a pilot for a major airline that I saw. And this is his first scan after he had an accident while he was, he has his own farm in Nevada. He basically fell off of a ladder, struck his head, had all these things, had to get managed. This is the scan initially. My point is he has hemorrhage, hemosiderin, subdurals, things of that sort right there. This, he completely clears up within 6 months. This scan looks beautiful. It's gorgeous. He's fully functional, no deficit. But here's where we get into a lot of issues. For traumatic brain injury, which is super common, we worry about their neurologic and cognitive deficits. And then it turns into a story about the risk of post-traumatic seizures and epilepsy. We know that for the biggest, there's a risk for seizures after traumatic brain injury up to 20 years afterwards. But you have to translate this to risk in this world. So there are three versions of seizures that occur in the traumatic brain injury. There's the immediate impact. There's no increased risk of post-traumatic development if you have an impact one. That's allowed. Does not portend epilepsy. But if you get a seizure within a traumatic brain injury within 1 week of injury, there's an increased risk of development, and that person is going to be watched for 2 years. They can't fly, and they have to be medication free. But if there's a seizure that occurs after a week, you have a 4 years or 5 years that you're going to have to be managed or watched before you can fly again. If you look at seizure risk after traumatic brain injury, this is what the FAA really sticks to. It really starts climbing. You get into that 95% threshold within 3 years. So that's where they come out with the 4-year rule, which is really turned into 5 years of watching these people, whether they look great or not, and their scans are okay, even with everything gone. And the reason is it has to do with, they still base it on the last set of trauma study and epilepsy was the Vietnam War studies, which were all mostly penetrating head injury. And that's where they had almost a 40 to 50% risk of epilepsy after a traumatic brain injury. Sadly, we haven't had better studies to predict epilepsy from traumatic brain injury, and that's where they use it. Now,
and Joe,
yes.
A quick question related to this, because this is something that we are asked all the time, and I know you have some expertise. What about those mild traumatic brain injuries, concussions, sports? Chris played a lot of sports, including hockey, football. Patients go down and they lose consciousness, or they're disoriented for a few minutes. They get to do it every day, every week, and over time. Do we know anything about those patients as to what happens over time for the risk of seizures?
No, for risk of seizures, the data is extremely limited. Most of the studies that have looked at those issues have been on population-based studies in Scandinavia, not even in the United States. So I will tell you that we don't even know how much you have to have in order to climb over that risk of epilepsy. It's not zero, but it's certainly not 40%. So we ended up with, I think from the population studies, about a 5% risk is what's quoted. And I might add for concussion, the FAA looks at that as a 6-month wait zone as opposed to any other thing. And that's just because that's the best they have at this moment. So on the larger, more severe ones, they're always worried about hemosiderin. And the reason is, as there's any hemosiderin that's cortically based, as the red cells and that hemoglobin starts to decompose, it releases iron. Free iron is very, very irritating to cortical tissue. And so this story is all about what happens to free iron released from hemosiderin. So that's an important point, because removing hemosiderin becomes an issue. And most of the FAA review of these cases is looking for hemosiderin. And that is what holds many of these pilots back. So here are the recommendations, mild 6 months, moderate 12 months, severe, they wait 5 years. That pilot who looked great at, I might add, about 7 months after, he's perfect. Neuropsych is normal, exams normal, scans are clear. He is still waiting because he has to wait 5 years before he goes back because of this issue until we know better. And that's where this is where these policies are made based on risk assessments. So we defer every traumatic brain injury to a panel at the FAA of composed of neurosurgery and neurology to make a determination. And I might add, hemosiderin, if it shows up on the MRI on the standard 1.5 Tesla, they're going to be stuck. Now, what we don't know, and I don't ask pilots to get this or see me, is 3T, 7T, where you pick up a lot more pathology, they won't fly. So this is where there are consequences to these decisions. Stroke, I'll make this quick as we get to the end. Same issues, cognitive and neurologic deficits. The risk per annum is huge. I will say that they worry a lot about AFib cases and cases that they do not have a good answer for. if your risk is over 1%, you're not going to be flying. So that risk of stroke has to be that 1% or less. If there's atrial fibrillation, and if there's no explanation, they want to know that if those have been mitigated. If there's a PFO, they want it closed. If there are issues with stenosis, what is that risk? This becomes a huge issue. A lot of people get upset about this, but this is how at least the risk has been assessed. On the tumors, it depends on whether it's progressive or not. Neurologic deficits, cognitive changes, seizures, and tumor recurrence. Meningiomas are the most common tumors we see in pilots. When they're posterior fossa, it's great because the risk of seizure is not so worrisome, but they have to have been managed and they do get flagged. These are the tumors that typically make it back to flight: meningioma, adenomas, ependymiomas, and then gliomas are considered disqualifying, but there are rare cases, which I've been shocked that they've made it back when they've hit past 10 years, those miracle patients that make it back there. They're looking for seizure recurrence, freedom from seizures, normal cognition, and no meds. So they're always looking on the FAA on this. They look for the natural history of that neoplasm, post-treatment observation for 1 or more years, and then current status reports. And they may allow someone to fly, but they'll force them to go see the neurosurgeon or the neurologist yearly with a scan so that they can assure themselves that it's gone. Like an oligo, they'll often do that before that they will allow them to fly again. So in conclusions, and I'm just trying to give you a flavor for all of this, neurologic conditions are very common in aviators. They're a common reason for grounding pilots. You need to be really in the weeds for the details, getting it right. Syncope versus seizure. Syncope gets you 6 months. A seizure will buy you 4 years. Epilepsy buys you 10 years. Stroke, 2, it's consequences. But if you get it wrong, there's the consequences that something horrible could happen. So this is a high stakes kind of game, which that's why there's so many people around it. History is everything. We're the linchpin in that gathering. I point out Mayo has a rich history in aviation medicine. There's a division of aviation medicine at Mayo. Jan Stepanek, one of the editors of the main textbook, he's based in Arizona. I will point out a couple of things. When once upon a time, when Northwest Airlines existed, Mayo Emergency was the ground to air consultation service for Northwest, which was then bought out by Delta. So we don't have that, but we have a long, rich history and connection with them. Number 2, we have wonderful colleagues in aviation medicine here in Florida, AME Harrigel, Michael Harrison Emergency Room. We have electives. We have things of that sort that are offered because this is a very important part. And I'll also add to those of you who are going to buy that $500,000 ticket to go to space with Branson and all that, those individuals, you need to have a class 2 medical certificate to fly as a passenger, even with that price. So you do have to be watched for these conditions, I might add. So, and that's how the space game gets into this mix as well. So with that, I'll say thank you. I know we're at time. Thank you so much for your attention. Happy to answer questions that I didn't see in the chat because I was trying to go fast to making the time.
Beautiful. I see Dr. Miller already with his hand raised. So we're going to take a few questions. It's okay. I know that we have the epilepsy conference, Joe. So we'll take a few minutes and then I monitor the chat. But Dr. Miller, do you want to and maybe take out the presentation, Joe, so that way we can see each other. Dr. Miller, take it away, please.
Yeah, Joe, thanks so much for the talk. Extremely fascinating stuff and well presented. I appreciate it very much. I have a patient who I've been seeing now for a number of years who has a small cavernous malformation in his frontal lobe. Generally benign. It was found incidentally. Obviously, I'm not certified in aerospace medicine and I don't certify. I mean, I've talked to Perry, a few people briefly about it, but I was wondering your thoughts. He is certified through a physician up in Atlanta. What I do is I check his MRI every year and I make a determination whether or not this lesion has changed and if there are any new lesions, et cetera. And it hasn't so far. So it's been fairly straightforward, and I'll certify that and send it back to his doc for evaluation. But, the calf mouths do change. They do have microscopic bleeding. Very often it's asymptomatic. It's really no trouble. But I worry a little bit if I'm going to run into one of these things where the appearance of this thing has changed slightly, a little more hemosiderin, whatever. Is that, and obviously I want to do the right thing for everybody, but I don't want to take him out if it's going to be something that doesn't have any clinical consequences. Where does all this fall in the spectrum of things?
Yeah, David, that is a fantastic example and one that's wrestled with all the time. If that pilot came up to a neuro review for the first time, it is most likely they will be held back for probably the 5-year mark or so because of their fact that it's cortically based and has hemosiderin. On the other hand, once you've reached that, they get to this category called special issuance, which is what I kind of pointing out. They're seeing you, they're seeing others, and they're watching and they're being monitored. In other words, they are watched like a hawk for that change. If something were to look different or worse, that license will likely just get pulled quickly. There's no, sadly, there's not, it's both good and bad. For the flying public and flying public safety aspects, this is the game. But for that person, that individual, they're stuck. There is not, until we find better ways of risk understanding for seizure, and that's what this story will turn into, the risk of seizure in that instance, even if he's never had one, until we know what predicts who's going to have one or not, we're in a situation. But I will tell you, David, if that was the first look at the FAA, that person would be held back with certainty. But in the subsequent ones like this, they're just watched by the regional federal air surgeon, and they watch to make sure that's the case. That's how serious it's all taken in terms of keeping the flying airspace safe, and at least that's the viewpoint.
Thank you, Joe. Thank you.
That makes sense for commercial pilots.
I got 2 more questions, one from Juan Pablo Navarro and then one from Gabriel Vargas. Juan Pablo, you want to ask your question, please?
Yes, doctor, thank you. It's just a quick question, and I might miss it, but my question is, do pilots undergo periodic MRI or CT images just looking for vascular abnormalities?
No, thank you. That's a great question. And thank God that they don't, because we would have a major pilot shortage. They do not. What they do undergo, one is that they basically have to do that examination. And part of that examination includes a vision test, a hearing test, an EKG, and lab work. And then the rest is the certification by their physician. So neurologically, they don't. But just as an aside, I can't help myself. I will say modern epilepsy monitoring units was created because astronauts for NASA had EEGs done on every astronaut. And that started the epilepsy monitoring units, arose out of the space program. I will say that, but they have stopped that because they're fearful that if you keep coming up with abnormalities in people who don't have a neuro condition, how do you interpret it? What does that mean? And I think the same is true in MRI, that if we keep finding that's the case. One last comment, there does seem to be an uptick for whatever reason. We see more tumors in pilots than others. And you have to remember, you're flying in an aluminum tube over at 36,000 feet. So there could be some inherent environmental risk in general.
Beautiful. One more comment and question. Thank you, Juan Pablo. One more, Dr. Vargas. Gabriel, I know you had a comment sort of question. Go ahead, please.
Yeah, thank you. I know that it's late, but just a question. Thank you very much for that. Very good recommendations. Just these recommendations should be transferred or translated to drivers or other people that, because we are on the other side, no? The patient wants to work and they say, doctor, I live from that drive. If you told me that I cannot drive what I'm going to do. So it's something that is really difficult sometimes for that kind of please sign that I can do it. What is your recommendation on that?
I love what you're saying. So so this is the part that makes it very hard. When the evidence is in front of me and people get very different about it. Some I get yelled at, screamed at because I'm giving them horrible news, not just that they're sick or that they can't do what they want to do, but I don't have a choice. I mean, these are legal government type of issues. And I remind them, I am on your side. If I can find a path, I'll find a path. I want you to fly, I want you to do this, but I can't undo this. And I try to advocate where I can to change laws with the policymakers, but it's slow. But to your point, it's not easy. There's not, in fact, I'd say that most of the time I've been yelled at, screamed at, or told off by a patient is about driving or flying. No question.
Thank you, Joe. Beautiful. Great talk, great questions, great engagement. We are so grateful to have you. And we're so blessed to have you also taking care of our pilots and the people who fly us, as you said, so many feet above ground, and that's, metal containers. So thanks everybody for such a great day, and have a wonderful, wonderful week. Sorry we're running late. I know you have epilepsy conference. So have a great, great day, everybody, and a great week. See you on Friday. Bye-bye.
Adios. Bye.
Adios.